Hi, my name's Rodney Neale. I'm the VTE Prevention Clinical Nurse Consultant at the Princess Alexandra Hospital in Brisbane. Really happy to be presenting this talk today. I'll be talking about VTE prevention and the new VTE Prevention Clinical Care Standard. Well, it's not so new. It was released this time last year, but this is a good time to go through it, I think. I'd like to thank Arjo for sponsoring this presentation. So as I said, we'll go through briefly an introduction to VTE in general, and then we'll be looking at the VTE Prevention Clinical Care Standard and going through the VTE Prevention quality statements in more detail. Also look briefly at what a standard is and also what a hospital-acquired complication, otherwise known as a HAC, is also. So firstly, some definitions. So venous, we're actually referring to a vein, and a vein is a vessel which returns blood towards the lungs, and a thrombosis is a clot inside a vessel which causes an obstruction. So when we refer to a venous thrombus, we're talking about a thrombus inside the venous system. And an embolism is a particle, usually a clot, which is moved from the vessel which it is formed and lodged in another part of a body. So when we refer to a venous embolism, we're actually talking about an embolism which has formed in the venous system and moved elsewhere. So VT really encompasses two conditions, and they are deep vein thrombosis, or DVT, and pulmonary embolism, PE. So DVT is clot generally in the deep veins of the legs, pelvis or arm, and a PE, as we said before, is an embolus which forms in the venous system, passes to the right side of the heart and lodges into the pulmonary artery. So DVT and PE equals venous thromboembolism. Why does this occur? Well, firstly, let's look at hemostasis. And hemostasis is a normal process and forms at the site of vessel injury. The response is pretty carefully regulated and involves the following phases. That is platelet plug formation. So platelets are the first responders in regards to clot formation. You could think of them as the bricks of the blood clot. So after platelet plug activation, platelet activation also leads to the clotting cascade, or amplification of the clotting process. And the end product of the clotting cascade is these fibrin strands, which along with platelets form the thrombus. So if you think of these fibrin strands as the mortar of the blood clot, the platelets are the bricks, the fibrin the mortar, we get a nice strong thrombosis that forms with other cells in the vicinity to stop the bleeding. And of course, we only want the clot to be as big as it needs to be, so we need some antithrombotic control. And then of course we want the removal of the clot after it's done its job, so the natural process is called fibrolysis. So that's the life cycle of a clot. Platelet plug, fibrin strands, they connect together to form a thrombosis, and then there's the breakdown of the clot after it's done its job. So this is a really simplified breakdown of a really highly dynamic and interwoven process. Bleeding or thrombosis can occur if any of these elements of this complicated process are missing what is functional. So in regards to venous thromboembolism, what causes this dysfunction? Well, it's generally related to three factors, and these are known as Virchow's triad. And one or a combination of the following will be present for a VTE to form. This being endothelial injury or vein wall injury, venous stasis, or blood not moving around the venous system as well as it should, or hypercoagulable state, meaning very simply the blood's stickier and more likely to clot. So these risks can be either hereditary or acquired. Not all are of equal value in regards to risk. However, it is important to know that these risk factors are cumulative. In fact, in a large study which looked at patients that acquired a VTE, 56% of them had 3 or more of these risk factors present. Later, when we look at some of the risk assessment models, it will become a little clearer as to the importance of the cumulative risks and how some risks are weighted and why every patient's risk is really unique and individual. So a little bit about DVT, signs and symptoms of DVT: pain, swelling, redness and warmth on the limb that's affected, whether that's the upper limb or the lower limb. So the therapeutic goals of DVT treatment: the first primary goal is to prevent a PE. Secondary goals: preservation of venous valve function, preventing recurrent thrombosis, and reducing complications such as post-thrombotic syndrome. And post-thrombotic syndrome is pretty under-recognized. However, it does cause significant morbidity, can have a negative impact on the quality of life of the person that's affecting. And it's not rare, it develops in around 20 to 50% of people post-DVT and is severe in around 5 to 10% of the cases. It's more likely to occur if you have recurrent DVT events or post an extensive proximal DVT, meaning you've got a DVT basically going up your whole leg. So the pathophysiology of the condition is incompletely understood, although chronic venous hypertension due to vein and valve damage and incomplete resolution of the clot certainly both play a role in the development of this condition. Post-thrombotic syndrome can manifest as a spectrum of signs and symptoms of venous insufficiency, and this can range from slight discomfort or swelling at the end of the day to severe pain and severe venous ulceration. So as stated before, one of the main treatment goals of DVT is to prevent a PE, and there are some pretty compelling reasons why. PE, 25% of people affected, unfortunately, sudden death is the first clinical sign that they actually have the condition. 5% die later despite correct diagnosis and appropriate treatment. PE accounts for 7% of all deaths in Australian hospitals every year, and it's one of the leading preventable causes of death in hospital. So signs and symptoms of PE are variable and unreliable for a number of reasons. For example, the size of the embolus can be different, where the embolus lodges, how many fragments of thrombus embolize, and of course the comorbidities of the patient also play a role. So the therapeutic goals of treatment for PE: number one, primary goal is to reduce mortality. Secondary goals to reduce thrombus propagation and prevent recurrent VTE, much the same as the secondary goals of DVT. And of course, reducing complications such as CTEPH or chronic thromboembolic pulmonary hypertension. And like post-thrombotic syndrome, this can cause significant morbidity. However, unlike post-thrombotic syndrome, it can also cause mortality, and left untreated, the prognosis is really poor. So thankfully the incidence of CTEPH is a bit lower than post-thrombotic syndrome. It's around 1 to 5% post-all PE. Again, the pathophysiology is unclear, but it's certainly initiated due to a previous PE event. And it's associated with organized thromboembolic material and altered vascular remodeling, which leads to pulmonary hypertension and right side ventricular failure. So So VTE isn't a rare event. It has a similar incident to the rates of stroke. Studies from all around the world have yielded pretty consistent results, with the annual incident rates ranging from 0.75 to 2.69 per 1,000 individuals in the population, with this incidence increasing to around 2 to 7% for those over 70 years. So the consequences of VTE are often under-recognised and their impact underappreciated. We've spoke briefly about CTEPH and post-thrombotic syndrome, but other consequences can include simply cost. A report by Access Economics for the Australian and New Zealand Working Party on the Management and Prevention of VTE in 2008 found the financial cost of VTE was estimated to be $1.72 billion, of which $1.38 billion, or around 80%, was productivity lost due to premature death of Australians with VTE. The total inpatient cost that year was $81.2 million. Along with costs, unfortunately also bleeding can be a consequence. Primary treatment strategy for both DVT and PE is generally therapeutic anticoagulation. And anticoagulation can be inconvenient, costly, carries a bleeding risk. The overall annualized major bleeding risk in large randomized trials was in a range of 1.2 to 2.2% during the acute or initial phase of VTE treatment. So VTE can also have high recurrence rates. Recurrence rates at 5 years after stopping anticoagulation range anywhere from 3% to 45%, depending on patient risk factors. And for those at the bigger end of the scale, around the 40 or 45%, this is seen as a chronic condition, which may also have long-term psychological consequences that have shown to include emotional distress, worry, and anxiety because of the uncertainty about whether or when a reoccurrence might occur. So therefore, in addition to the physical burden of VTE, there's also an underappreciated emotional burden that can be associated with this condition also. What's the good news? Well, we know up to 75% of all VTE occur as a result of a hospitalization, and that good VTE prevention strategies can reduce the development of these VTE from anywhere from 55% to 70%, of course, depending on the patient's acuity. So the Australian Commission, Safety, Equality and Healthcare certainly deemed VTE prevention to be important and released VTE clinical care standard this time last year, and the major goal of this standard is to reduce the avoidable death or disability caused by hospital-acquired VTE. So really quickly, what is a clinical care standard? Well, importantly, it's not a guideline. However, it does address priority areas of the patient pathway where the need for quality improvement is the greatest, and it does this through its quality statements, and these quality statements describe the clinical care a patient should be offered for a specific clinical condition. So in a nutshell, the VTE clinical care standard is basically the minimum care requirements the Commission expects all facilities to do in regards to VTE prevention. So who is within scope of this VTE clinical care standard? If you're a patient, if you're admitted to hospital ward, general surgical medical ward, some day procedure services within scope, certainly those patients that are going to go home with reduced mobility compared to their normal state, or that require prolonged anesthesia, or have known multiple risk factors for developing VTE. Also some patients, certainly not all patients, but some cohorts of patients that are discharged home from ED. Again, it's all around reduced mobility, and importantly, especially those patients that may be going home with lower limb fractures or lower limb injuries that require immobilization with plaster cast or a brace. certainly need to be considered for VTE prophylaxis and get a risk assessment. And of course, pregnant and postpartum women are also within scope. In regards to facilities, all public and private hospitals are within scope, as are subacute facilities such as rehab, palliative care, and mental health units, and GPs and other community settings where ongoing monitoring and reassessment of VTE risk are required to prevent VTE following hospitalization. And this last point will make more sense when we go through the last clinical care statement. So there are 7 quality statements in regards to VTE prevention, which follow a patient's journey from admission to discharge, and for some patients into ongoing care. So we'll look at these 7 statements in a little bit more detail now. We'll go through them one by one. So the first statement, it's all around risk assessment and documentation of that VTE risk. So it states a patient potentially at risk of VTE receives a timely assessment to determine their need for VTE prevention. And there are several different risk assessment methods available, all of which have their pros and cons. We'll go through a few right now. So there are those risk assessments that classify VTE risk based on a cumulative score of risk, such as the Padua or Caprini risk assessment models. These give you an individualized risk assessment score based on the patient's individual risk factors and assign a patient to either a low or moderate or high risk category. These types of models are seen by most international guidelines now as best practice in regards to risk assessment, as you are less likely to over or under prophylax. However, the major drawback is that they are sometimes cumbersome and time consuming to complete for the clinician. So another model commonly used is a risk factor recognition, or a buckets of risk method, by which patients are assigned either a high or low risk category based on risk factors and admission reason without assigning a score. This model is really efficient for those patients that are coming in for high risk procedures or conditions that have an obvious high risk factor. However, they're not great for discerning risk of those grey area patients, and there is a risk of either under or over prophylaxing due to this. There is also a combined model which uses the best of the previously mentioned methods. These models allow a buckets of risk method to be used for obvious high risk patients, so clinicians don't have to take the time to do an individualized assessment when it's not really that necessary. But for those grey area patients, it moves towards an individualized score-based risk assessment model such as the Caprini or the Padua. It's sort of a best of both worlds risk assessment tool that captures the better aspects from the other models. Certainly the Queensland statewide risk assessment tool, which was developed last year, is a really good example of one of these models. So first question, who is high risk for VTE? Not who is higher risk, but who is high risk? A, Mr. Virchow, an 85-year-old gentleman, day 1 post the left total knee replacement. He is otherwise generally fit and healthy with a BMI of 22. B, Mr. Virchow's 42-year-old daughter has presented to emergency department with a lower limb fracture. Her leg has been placed in a cast and she's been asked not to weight bear until follow-up in fracture clinic in a couple of days, and has been provided with some crutches. Her BMI is 48. She has a known thrombophilia and she has a history of a DVT post a long haul flight. So who is at high risk? A, B, or A and B? I'll give you Right. Yeah, they're probably both would be seen as high risk. Mr. Virchow's an 85-year-old gentleman. Any major surgery over the age of about 40 is putting you at higher risk, and certainly left total knee replacement, lower limb orthopedic operation is seen as a high risk operation in regards to VTE risk. So although he's pretty generally fit and healthy and his BMI is fine, he would still be high risk just because of his admission reason, and that is because of the operation he's going for. His daughter certainly has a lot of risk factors in regards to VTE. We've put this one in as an example of those ED patients that probably need to be considered for prophylaxis on discharge. She has a lower limb fracture. Her leg's been immobilized in a cast. She's not to weight bear, so that cuff pump isn't working. She's got a high BMI. She has a known thrombophilia. She has a history of a DVT. So she has multiple weak, moderate, and she has some high, strong risk factors in regards to DVT development. So we know now these Mr. Virchow and his daughter are at high risk of VTE. What's the next step? Do we just order prophylaxis? Here's your chemical prophylaxis. See you later. No, we got to think about. So if you're considering giving prophylaxis to Mr. Virchow or his daughter, what's the next thing to think about in regards to VTE prophylaxis and VTE prevention? Well, if you're considering giving pharmacological prophylaxis, you've also got to take into account the patient's bleeding risk. So the second quality statement is all around developing a VTE prevention plan, balancing the risk of VTE against risk of bleeding. And of course, things that clinicians are thinking about is what's the patient's likelihood of bleeding? Is it high or low? And what are the consequences of bleeding if it occurs? Is it more likely to be minor, or is it likely to be catastrophic? So there's a couple of absolute contraindications where we certainly wouldn't want to provide prophylaxis. Number one, if the patient's already anticoagulated, they certainly don't need a prophylactic dose on top of a therapeutic dose. And the rest is all around really bleeding. Are they active major bleeding, recent clinically significant bleeding, high risk of bleeding with thrombocytopenia, platelets below 50. This is especially relevant to oncology patients receiving chemotherapy. And if they have any inherited or acquired bleeding disorders such as hemophilia. So a lot of those things are really pretty much common sense. And then you also have a lot of relative contraindications where certainly where you need to document, the clinician needs to document really well in regards to their decision making around this. So it might be right not to provide prophylaxis, or it might be right to provide prophylaxis. However, it just needs to be documented how their decision was made. So next question. A 32-year-old male is admitted via ED to ENT with nosebleed, a significant nosebleed. A rapid rhino device, a catheter has been placed up his nose to stop the bleeding, and he's receiving 1 unit of the 2 units of packed cells that are ordered. On review of his nightly meds, you notice that at 8 o'clock at night he has been ordered for a prophylactic dose low molecular weight heparin. And this 32-year-old male has no other VTE risk factors. He's pretty mobile. He's getting around. His BMI is fine. He's never had a blood clot before. So, A, would you administer the medication as ordered? B, would you withhold the dose at night? C, would you contact the doctor and ask why dalteparin has been ordered when the treating team usually prefers a morning dose over a night dose? Or D, would you contact the doctor and discuss that the patient's bleeding risk is high and his VTE risk is low, and that maybe we should reconsider whether pharmacological VTE prophylaxis is necessary? So again, I'll give you So for this gentleman, hopefully you contacted the doctor and discussed that the patient's bleeding risk is high and the VTE risk is low. He's a 32-year-old gentleman. It's not stated that he has any significant VTE risks. He's come in, he's actively bleeding. You wouldn't want to give prophylaxis on top of that. And I gave this example because sometimes in surgical wards, especially, some blanket ordering can occur where everyone who comes in gets VTE prophylaxis, and certainly this is where risk assessment and bleeding risk assessment is really important, so these things don't occur. Look, B's not totally wrong with holding that dose at night, would be correct, but really the best course of action is to get the order ceased, because you withhold it that night, the order still stands. The next day he might get a chance of getting the prophylactic dose, which might be enough to kick his bleeding off again. So quality statement number 3, to inform and partner with patients. Really easy one to do, but probably one that's not done really well. It just says patients should receive information and education about VTE and ways to prevent it, and that they're involved in decision making. And look, a lot of discussion points, a lot of conversations you can have with the patient. Certainly when you're putting stockings on or putting the calf pumps on or giving the medication, you can always discuss VTE. These are the signs and symptoms to watch out for when you go home. These are the things you can do to try and prevent it when you go home. These are the things you can do in hospital to try and prevent it. And of course the importance of preventing it, that this can be, for some unlucky few, a fatal event. So 4, document and communicate the VTE prevention plan. So a patient's VTE prevention plan is documented, communicated to all clinicians involved in their care. This is really important. I see VTE prevention as a team game where nursing staff, doctors, pharmacists and physios should be all on the same page and know exactly what a patient's VTE prevention plan is. And there's plenty of places where you can document this. My recommendation would be for your unit or division or even facility, if you can document in roughly the same place, if you stay consistent, so people know where to look for it. And, this can be the NIMIC or the National Medication Chart, National Inpatient Medication Chart, in the medical record or on the approved risk assessment form. So an excellent place to document the VTE prevention plan, of course, is in the VTE section of the NIMIC. Importantly, in this section, to break the section down, firstly, we have an area where the doctors can write whether a risk assessment's been attended or not, whether the patient is at risk or not at risk, or prophylaxis not required. The next section is the chemical prophylaxis, and the next section is mechanical prophylaxis. Importantly, in the mechanical prophylaxis section, if you see here, nurse initiated signature. So this is saying that mechanical prophylaxis is just as much the domain of the nursing staff as it is of the medical staff. And I think the nursing staff are willing to make decisions on mechanical prophylaxis, but sometimes documenting them is a different story. Certainly this area is also a good way to document any contraindications that may exist to VTE prophylaxis, whether that's in the chemical or mechanical section of it. Another recommendation I would make is, under that contraindicated is actually write why. So if that's a contraindication to pharmacological prophylaxis, it might be worth also writing in there already on therapeutic anticoagulation. The more information, the better. So really good recommendations in regards to how to use this section is on the Commission's website. please go to it. Easy to download, easy to have on the ward, great for the pharmacists, doctors and nursing staff on the ward to know exactly how to use it. So just to digress for a moment, but I think it's very relevant, this VTE prophylaxis section is right above the warfarin ordering section on the NIMIC, and this was done on purpose because obviously if you're on full therapeutic warfarin, you generally don't need VTE prophylaxis on top of it. So it was a visual cue that if you're on warfarin, maybe VTE prophylaxis isn't indicated. However, since this document was last reviewed, a lot of the newer oral anticoagulants such as rivaroxaban, dabigatran and apixaban are being used in greater numbers, and these can be written anywhere on the chart and really does put the patient at risk of being co-prescribed therapeutic anticoagulation and prophylactic anticoagulation at the same time, and certainly there has been events that have been related to this. So always be aware, point out to the pharmacist, talk to the treating team if you notice that this section hasn't got a contraindicated line through it and they're on one of these newer medications, or if they're on one of the newer medications and also on VTE prophylaxis, certainly point out to the pharmacist or the doctors to get that prophylaxis ceased. So the big one, use appropriate VTE prevention methods. If we're going to provide VTE prophylaxis, we should provide it optimally. And the three main prevention methods are pharmacological or chemical, mechanical, and primary methods. So we'll go through these individually. So briefly, just look at pharmacological prophylaxis. We have our low molecular weight heparins, which include, well, there are actually a couple, but the most commonly used ones in Australia at the moment are clexane and enoxaparin and dalteparin, also known as Fragmin. These are once a day doses generally. If you're a standard weight, so the standard dosing for clexane is 40 milligrams once a day. Standard dosing for Fragmin is 5,000 units once a day. Low molecular weight heparins in most of the newer updated guidelines are the preferred agent for VTE prophylaxis for a number of reasons. They are thought to be a little bit more efficient, there's less bleeding risk, and certainly a lower risk of hits than with normal, with old unfractionated heparin. Also at the moment, well, especially in Australia, I'm assuming there's a worldwide shortage of heparin. They're certainly more cost effective than unfractionated heparin at the moment also. So unfractionated heparin. So this is standard dosing of 5,000 units, BD or TDS. It's got a shorter half-life than the lower molecular weight heparin, so it needs to be given more often. This shorter half-life is seen by an advantage by some surgeons who would prefer unfractionated heparin because it's in and out of the system quickly, and it's also, unfractionated heparin is also 100% reversible with protamine, just in case there is a bleed. Low molecular weight heparin is only around 60 to 70% reversible with protamine. So unfractionated heparin does have some advantages. Its other major advantage is that it's not renally excreted, therefore it is the agent of choice for those patients with severe renal impairment. So they're the general medical, surgical, prophylactic heparins, low molecular weight heparin, and unfractionated heparin. Now, some of the newer oral anticoagulants are indicated for elective total hip and total knee replacements. That's the only indication in Australia that they have at the moment. These DOACs, apixaban, rivaroxaban, and dabigatran. As I said, at the moment they're only indicated for specific orthopedic operations, as is aspirin. Which went out of favour in regards to VTE prophylaxis for a long time, but a lot of the newer guidelines are accepting aspirin for specific low-risk orthopedic operations, and the dose of aspirin is generally 100 milligrams once a day. So, question. A 62-year-old female, day 4, post-right total hip replacement, has been commenced on therapeutic rivaroxaban 15 milligrams twice a day for a newly diagnosed acute right DVT. On review of her nightly meds, you notice 5,000 units of unfractionated heparin is ordered at 8 o'clock that night. You would A. Administer medication as ordered. B. Contact the doctor and discuss that the patient has commenced therapeutic anticoagulation and that pharmacological VTE prophylaxis order should be ceased as now contraindicated. C. Contact the doctor and ask why unfractionated heparin is ordered when low molecular weight heparin is recommended post total hip replacement. D. Withhold dose that night. Again, great. B. You would contact the doctor and discuss that the patient now is on therapeutic rivaroxaban. They had a dose that morning, therefore a dose at the same time that unfractionated heparin is ordered, so you would not give both. They don't need both. They're on the therapeutic dose. They do not need the prophylactic dose. It's certainly contraindicated. Withholding the dose at night isn't totally wrong, but as with the example before, you would much rather get it ceased because the nursing staff in the morning may not actually pick it up and then give an injection of heparin and also give a DOAC on top of it. So yes, B is the correct answer. So mechanical prophylaxis. When we speak of mechanical prophylaxis, we're usually talking about foot pumps, calf pumps, and also compression stockings or graduated compression stockings. You'll often hear them referred to as scuds and TEDs, but both these are brand names. You should really call them by the correct terminology, which is intermittent pneumatic compression and graduated compression stockings. Okay. Now, mechanical prophylaxis is usually indicated for high to medium risk surgical patients and for high dependency unit patients. Generally, it's not indicated for medical patients. However, if a medical patient is contraindicated to pharmacological prophylaxis, you may consider using mechanical prophylaxis instead. But generally, rule of thumb is mechanical prophylaxis is a surgical domain. Most of the newer guidelines are preferring IPCs over graduated compression stockings now because they see them as being slightly more effective and efficient. So factors to consider in regards to intermittent pneumatic compression: ensure correct size and fit as per manufacturer's recommendations. You can apply them over trousers and socks. Certainly with intermittent pneumatic compression, also you can apply them when people are sitting up in the chair, especially those surgical patients that are sometimes sitting up in the chair for 2 or 3 hours a day. Put the foot pumps on, put the calf pumps on, they work. Of course, pretty simply, ensure connections are secure and pressure is appropriate, and wear for the bedbound patient for around 16 to 18 hours a day for it to be optimally effective. So, question: what best describes IPC application? A. Apply, connect, start. B. Start, apply, connect. C. Apply, connect, don't bother pressing start, and just walking away. And hopefully you chose A, apply, connect, start. Often I will see these pumps beautifully put on a patient, such as the picture there, and then the device not commenced or started. It's just a waste of time. So please, the correct application, of course, is to apply, connect, and then start the device. So factors to consider for graduated compression stockings: again, measure and fit as per manufacturer's recommendations. All facilities use different stockings, so please be familiar with what stockings your facility is using and how they recommend to measure and fit, because if they're not the right measure and fit, they may as well not be on. It puts a patient at risk of getting, 1, a DVT, and 2, of getting a pressure injury. The caution with ulcers and wounds, of course, common sense stuff with these stockings: wear day and night, but make sure you monitor and look at skin integrity and neurovascular status. Don't roll or fold, and please wear footwear when mobilizing. So, question: which is correct, A or picture B? Hopefully you chose A. B, see this all the time when you walk around hospitals auditing. This is what happens when you guess. Please always measure and fit appropriately. So some practice points: IPCs, you shouldn't use on a limb with a known or suspected acute DVT. There's a slight hypothetical risk of clot mobilization, but more importantly, just something banging up and down on the blood clot tends to hurt the patient. Don't use on patients, especially the foot pump. Don't use on patients with CCF or other conditions where increase of fluid may be detrimental. Increase of fluid to the heart may be detrimental. Certainly, as I said, this is more for the foot pump than maybe the calf pump because it works at a high pressure. Sometimes foot pump can be used for people with peripheral arterial, peripheral vascular disease under vascular specialist guidance. Graduated compression stockings, they can be used if the limb has a DVT. I'll often get this question: do we have to also remove the graduated compression stockings if they have an acute DVT? And no, the preference is actually for a grade 2 garment, compression stocking with a little bit more compression. So no, it's certainly not a contraindication. And look, if someone's on predictable therapeutic anticoagulation, such as the newer DOACs, or their INR's 2.6 on warfarin, or they're on therapeutic clexane, then mechanical prophylaxis really becomes redundant, and it's just another thing to create a falls risk or a pressure injury risk. So please, if they've been commenced on therapeutic anticoagulation, then consider removing mechanical prophylaxis entirely. So primary strategies, really important: good nursing cares, good hydration, good nutrition, and mobilization, of course, is the best mechanical prophylaxis you can get. Statement 6 says to reassess risk and monitor for VTE related complications. So reassessment should happen every 7 days, change of clinical condition or change of goals of care, and on discharge from hospital. And what are we monitoring for? As I said before, we're looking for bleeding. What's their HB doing? What's their platelet doing? What's their renal function doing? We're looking for thrombosis, so they actually have signs and symptoms of a DVT or PE, and those medicine or device related problems. So transition from hospital to ongoing care. Last one, we're nearly there. So a patient at risk of VTE following hospitalization receives a written discharge plan or care plan before they leave hospital. Basically, if someone's going home on extended prophylaxis, that the patient should know what they're doing, the carer should know what's going on, and the GP should know exactly what's going on. Pretty simple. So we've put all these things in place through our facility, and you want to know how well you're going in regards to your VTE prevention efforts, and if you're improving or not. So how can you tell? Well, you can look at data that's already been acquired, and this is data that's been collected routinely as part of the hospital-acquired complications list. And through coded data, and certainly in regards to VTE, some of the outcome indicators are rates of hospital-acquired DVT, rates of hospital-acquired PE, and rates of bleeding due to circulating anticoagulants. So monitoring these three things will give your facility some idea of how you're going in regards to the appropriateness of your prophylaxis. So quickly, what is a HAC? A quick description: a hospital-acquired complication refers to a complication for which clinical risk mitigation strategies may reduce but not necessarily eliminate the risk of that complication occurring. And I think that describes VTE to a T. And VTE is number 7 on the list of 16 HACs outlined by the Commission. There's other local things we can do in regards to auditing or assessing how our units or divisions are going in regards to VTE prevention. We can audit how many people are getting a risk assessment within 24 hours of admission. We can audit the appropriateness of the prophylaxis they're getting, and we can certainly audit if they're going home on extended prophylaxis. What's the quality of information that we're giving to the patient, to the carer, and to the GP. So these are 3 local indicators that the clinical care standard suggests that facilities start acquiring. So thank you very much for listening. I did this talk as a webinar a couple of weeks ago, and unfortunately there were some technical issues, so this has been a re-recording a couple of weeks after the fact. No, it was a bit clunky, but it was nowhere near as clunky as the webinar I gave. So well, thank you for listening, but more importantly, what you should take out of this is how important VTE prevention is, and that there are certainly good resources around to try and help your unit, your division, your facility in regards to reducing the burden of VTE on both the facility and more importantly to the patient.